working on RPIW number 27, which was addressing the pre-anesthetic clinic. So this is our team member and their order of presentation, and they'll be introducing themselves as we go through. So this is everyone together. As you can see, we're a very large group, so I apologize if you feel this report out is rushed. We have very limited time for everyone to get to say their piece from there. So the theme, what we were trying to work on of this project was to standardize the flow of the pre-op assessment clinic to increase its capacity and increase the value-added time for the patient, and while decreasing the defects that could result in eventual postponement or cancellation of the surgery. The goal of this RPIW was basically to leapfrog eventually to another one where we could have all of the preoperative testing and screening done in one stop, but this was kind of an RPIW to lay the groundwork for that to happen in the future. So this is kind of talks about why we needed this RPIW. When we looked at all of the information and processes that the patients had to go through and how they got to PAC, it was really quite surprising that anything ever got there at all. Because all of these different documents could start at any of these boxes along the journey and could go in any direction to any of these other places on that chart. So like I say, very surprising anything actually got to PAC in the first place. So these are our value stream maps. What I just want to highlight is we originally started out with PAC occurring in 2 different places. So it occurred up in day surgery, and there was another PAC that occurred down in therapies. They ran completely differently with different providers and very different processes. So one of our jobs was to try and figure out what was the best benefit of the patient in an overall experience. So the next thing that we're going to talk about just quickly is the key things we're going to pull from our target sheet, where we were looking at the defects in the process. So how often were patients arriving to PAC with missing information? And that was 100% of the time. So we spent some time and energy into trying to improve that process. As well, we were looking at the productivity or the capacity of PAC. We really wanted to make sure we were getting the right people into PAC, and that because we were pulling together a lot of professionals in one place, we wanted to make sure we were using their time to the best and making sure that we were using the capacity that we had. So Taylor spoke to the takt time. For this experience, it was 52.5 minutes. And if you look at the standard work combination sheet that follows, the takt time is marked in red. So that's the process for one PAC visit. And you can see that although the service was really good, they were running into scheduling process and extra defects because they were way overshooting their takt time from there. And then this is our percent load chart. So you can see kind of what amount of time the medical office assistant, pharmacist, and anesthesiology were spending, and that they weren't leveled, and we wanted to work towards distributing the tasks evenly. The other thing to pull from this is that all of the bars that are kind of slashed there is indirect patient time. So there was a lot of background work being done to make this process run, which was taking away from the efficiency and flow for the clients. So I think I'm going to pass over to Joanna.
One of the first things that we tackled during the week was to try and come up with our ideal for how a pre-op should flow right now without a one-stop shop. We identified a lot of barriers that we're all running into trying to get all the information together in a timely fashion, especially now with our short wait list. So a number that we couldn't identify or address were complicated unassigned patients and patients from the north that all need their pre-ops and they all need their information brought back here, so we're hoping another RPIW could look at that. What we did address during the course of this RPIW, one of the problems was the ECGs arriving at the PAC clinic almost unreadable, probably because they were faxed from where it originated to the family doctor's office, then to the surgeon's office, then to to OR booking. So one of the changes we made is that ECGs are going to be faxed directly to OR booking when you're done for pre-op. Another of the issues was all of the labs being done around the city, and it was difficult for our patients to travel to all the different locations, and so our lab and diagnostic imaging has agreed to allow patients to come to the hospital for a one-stop shop for their diagnostics prior to surgery. And finally, because of the short time in the bookings now, we were having trouble getting PAC appointments in a timely fashion because the rule was that we had to have full packages before we could give an appointment to a patient. I know our scheduling has agreed to work with us to allow us to book the PAC appointment prior to completion of the packages, with the caveat, of course, that we have to have a full package in at least 48 hours before that appointment, or the appointment will be canceled.
I'm Brenda Hicks, MOA for Dr. Woodley. In our new process, surgeons' offices, MOAs are encouraged to have their patients fill out the PSAQ form while in the office, which can then be faxed to their family physician, and then the original sent with the patient for their GP appointment. During that time, the surgeon's MOA is able to call the patient's family physician to schedule a pre-op appointment within 1 to 2 weeks. And if deemed by the surgery, we will also be able to schedule an internist and a PAC appointment prior to having a complete package schedule or scheduling. This will meet our target of seeing all the appropriate patients in a timely manner. This process is a huge benefit to our patients. The patient receives all of their appointments in written form. Even before they leave the surgeon's office, they only have 1 contact person versus 4 as previous. This process is not more work for the surgeon's MOAs. It's different work in that we are not having to spend copious amounts of time making phone calls, searching for missing PSAQ, lab results, pre-ops, etc. We used to have 2 separate checklists for PAC and non-PAC patients. In our new process, this has been replaced with 1 checklist, which will now be the same as the front of our revised brown envelope, which will also include check boxes for what labs were ordered and received. This will improve the flow of information between providers and standardize patient access to PAC, as well as reducing the number of pre-op packages arriving at PAC with missing information. Our process owner, Dr. Litsinski, has kindly agreed to do a roadshow to visit approximately 146 healthcare workers, which will include all the surgeons, family physicians, and support staff within Prince Albert. He will reiterate the importance of sending out all pre-ops and labs to surgeons in a timely manner, as well as educating them on our new process. He will also be handing out the pre-operative assessment guidelines, and I'll pass it over to Dr. Chow.
Hi, I'm Rowan Chow. I'm the lead assistant for Albert. So I was tasked with the pre-operative assessment guideline and access lab investigations for our anesthetists. Credit goes to Dr. Stevenson for actually creating the 1-page guideline for CC. The objective for the 1-page pre-op assessment guidelines were to condense all documents from the anesthetist, previous RPIW, the SMO memo, as well as research data to 1 single page, as you can see there. It should also be user-friendly, easily readable, applicable to the majority of our surgical patient population, applicable to our physicians, specialists, family physicians, as well as nurse practitioners. And lastly, it should also be very self-explanatory. And that's the new document in 1 page. This is the 1-page pre-op assessment guideline, and because it's quite self-explanatory, I'm not going to go through it at all. Okay, my last task was to ensure that all anesthetists have access to all lab investigations and X-rays, and this is either through eHealth, through PACS, SNM, SCM, as well as associated radiology. That's through telehealth. IntelliViewer, sorry. And currently, this is being done as we speak. So I hand you over to Pat.
Good afternoon, I'm Pat Weiss. As a patient participant in this RPIW, I've seen how this process works using 2 different departments. Previously, the doctor PACs were all done in day surgery until about 1.5 years ago. They're now being done 3 days of day surgery, 2 days of therapies. As a result of this RPIW, a decision has been made to do all of the doctor PACs and therapies 2 days a week, with the possibility of adding a 3rd day if necessary. The reason for this decision is there's not a dedicated MOA in day surgery, and it is an extremely busy department with a lot of traffic and congestion. Therapies appears calm and reasonably quiet with easy access to it for both the patient and the anesthesiologist. It may be a little further for the patient to walk from admitting, but if there's a mobility issue for the patient, they can be dropped off at the north entrance of therapies, and that person bringing them can go to admitting and register them. The patient is then kept in 1 department with minimal moving around. By going to 1 standardized clinic, it makes it easier for the patient, as now some patients go to day surgery and are told they should get therapies that day, which may result in an irritated patient by the time they arrive at their home. I'll turn you over to Monique.
I'm Monique Swap, and I'm the pharmacist that currently works in the pre-anesthetic clinic. One of the ideas I helped explore was regarding communication between the care providers during our clinic. We found that we each worked individually with the patient but didn't schedule ourselves time to communicate with each other. And we felt that in doing that, we were providing redundancy in our process because we were often asking this patient the same question over and over. We also identified that we weren't having a formal process at the end of our patient appointment to provide formal instructions. We were all providing instructions randomly throughout the appointment, and that maybe wasn't the most effective way to instruct the patient. So we made a new workflow process, which involved having each individual communicate with the next care provider prior to them entering the room. That way information was shared, ideas were shared, and the patient ends up having a higher quality service as well as improving efficiency with the care providers. The other thing we did is ensure that our process includes a specific teaching moment at the end of the appointment where the medical office coordinator sits with that patient and provides all the pre-op instructions all at once. I'm going to pass it over to my medical office coordinator, Deb.
My name is Deb, and I'm the medical office coordinator, currently working in the Dr. Pat Clinic in the Therapies Department. Prior to this RPIW, the Pat Clinic in the Therapies Department would see an average of 5 patients per clinic, with the first patient arriving at 9:30 and the last patient arriving at 2, which allowed for an average of 45 minutes per patient, with each patient seeing 3 care providers, one after the other, starting with myself, medical office coordinator, then the pharmacist, and finishing with the anesthetist. By simply changing the flow of the providers and adjusting patient start times, we are now able to see a minimum of 6 patients per clinic, starting at 9 and finishing by 1:35. We completed this change by speaking with the scheduling department and creating standard work for the scheduling department to allow for booking the patients based on whether the patient is a simple or a complex patient, and booking them into designated simple or complex time slots. Secondly, we adjusted the flow of providers, and lastly, by staggering patient appointment start times, it allowed for a slight overlap. We believe that this has created value-added direct patient care time and has reduced unnecessary downtime for all 3 care providers. In making these changes, we have not affected the number of patients seen in each clinic or the amount of time directly designated to each patient's appointment.
Hi, I'm Linda McKinnon. I'm a registered nurse in the day surgery unit, and I'm speaking on the work standard created for the pre-anesthetic clinic, or PAC as it's referred to. And this is now a 3-part process. Part 1 outlines how the medical office coordinator or MOC or medical office assistant MOA prepares for the PAC appointment. Part 2 is the actual PAC appointment. This part outlines the roles of the 3 providers, the MOC, the pharmacist, and the anesthetist. The MOC is the initial contact for the patient and family. She ensures identity and comfort, gathers pertinent data, and gives a brief explanation of the PAC appointment for the patient. The pharmacist is responsible for gathering the best possible medication history, or the BPMH, from the patient and family, and she shares this BPMH with the anesthetist. The anesthetist receives the past and present medical surgical history, reviews the past and present medical history with the patient and family, completes a physical examination if required, provides verbal and written pre-op instructions, and offers opportunity for questions. The MOC again then meets with the patient and family to review and provide written instructions for the pre-op surgical preparation. The final part of the PAC is the gathering of all the PAC documents by the MOC. By placing them into the brown pre-op envelope, she then documents on the front of the envelope any pending investigations or reports. This envelope is then returned to OR scheduling. Previously, this envelope would have been taken to day surgery staff for day surgery to complete and then returned to the OR scheduling department. I'll turn it over to Wanda.
Hi, I'm Wanda and I work in the OR scheduling office, and I was tasked with doing 5S duties for this event, and so I did spend pretty much an entire day doing that with Val. I have pre-5S pictures here. This is a shelving unit in the OR scheduling office, and also covered space just to the right of that shelving unit. You'll notice that there's lots of stock, miscellaneous items on the top shelf, lots of unlabeled shelving, items that are unused or unnecessary, boxes of supplies on the floor there blocking the shelving behind. Post 5S, very dramatic difference. Unnecessary and unused items all gone. Supplies are more accessible and properly labeled. Countertop is clear. The second picture just shows a bottom cabinet. Whole bunch of assorted stuff on the top there. Found a proper home or have been eliminated. And eliminated items took 2 carts. Next picture is of all the items that were removed from the area entirely, 155 items in all. So our pre-event F5S score was 1.3, post-event was 2.7, so that's a 35% improvement. We reduced our inventory count by 41%. We reduced the space used by 26%. And we also addressed one safety defect. On the side of the shelving unit is a fire extinguisher, which wasn't easy to see from every area of the room. So there's now a visual cue there as to the location of that. And we do hope to improve this score with the continuing development of standard work practice.
I'm Cheryl Elliott, and I'm sub-team lead for the RPIW. This is our waste wheel pre-Kaizen, and as you can see, there's a significant amount of waste in the areas of weighting, transportation, and processing. Post-Kaizen, we see that we've made gains after our changes by removing about 46% of our waste that we had identified pre-Kaizen. Our value stream map, the most significant thing we can notice here is there's only one flow because we did make the change to go to one process. And there actually was a 17% change in the lead time of the process from to 1 hour, 1 minute, and 40 seconds. That would have been an even more significant change to 1 minute. So our value added time was around 78%, which was between the two processes in the first value stream map. This is our standard work combination sheet, and what the most significant thing to note here is our process now comes a lot closer to meeting takt time. There wasn't a great deal of difference in our flow of our patient. This is our percentage load chart, and what this does still show us is that given the direct and indirect time of the providers, the reason why we went to the 2 appointments closer together and then being ready for the anesthesiologist during these tests is that they had a little bit less time with the patient, so they would need to have people ready to see them. So we're not having providers waiting either. This is our target sheet, and the main items we want to point out on the target sheet are our defects. We went from the 100% defects as to the packages arriving with missing items in the therapies department for PAP to 60%, so an improvement of 40%. And also, the other item was a productivity gain. We saw that pre-Kaizen we had 71% of our appointments being used and 83 at the end of our. In our newspaper, there's several outstanding items, but the majority of them are to do with education on our standard work and process changes. We do have the joy of several people being involved in the front of this process, so we need to make sure everyone is aware. We also have to follow up on a future expansion to 3 days in the therapies department, because at this time we are about 2 appointments short for the week based on demand now, so we will have to see if we can fit one more in. And also there's a piece around making technology available for the anesthesiologist that's not quite. Ron?
Thank you, Carol. The issues discussed sound very dull and bureaucratic, but in fact they ensure the safety and the ability to be able to operate on the most complicated patients that we have in our district coming to surgery. It's close to the heart of our sponsors and our process owners. It's an area cited in the Virginia Mason literature as an area that caused meltdown and needed very innovative interventions. We were pleased that we didn't need to be quite so innovative here. I'd like to show you the workshop summary. There are so many people to thank that I would particularly like to thank Brad in the print shop, who 2 days after a big family wedding was prepared to work through his lunchtime to print for us. Thank you to everybody else. Please look at our wall. Have a happy Thanksgiving from the turkeys of RPIW 27.